Hey, and here we go. We have almost 200 people on the line, which is fantastic. So, really appreciate you all signing in this morning, or this evening, or this afternoon, wherever you are. Clearly, there's a real hunger for the information that we'll be discussing today. So, my name is Kate Lane. I am the Director of Adolescents and Youth here at FP 2020. Again, thanks for joining this webinar to learn more about the biases that providers may have with regard to providing contraceptive services to young people. And many of you are likely very familiar with FP 2020 as part of our efforts to empower women and girls by investing in rights-based family planning. We've been really building out our efforts with our partners in country and with partner organizations and our donors to help partner countries strengthen their responses to the needs of young people. Young people have long cited the judgmental attitudes of healthcare providers and the unfriendly environments of health facilities. And as many of you know, our most popular response to change provider behaviors and attitudes has been through training, often an in-service training, opportunities for providers or of different cadres to learn about adolescent development and adolescent health and effective approaches to counseling and communicating with young people. But we know this kind of training has often been woefully insufficient. So under the leadership of my friend and colleague, Gwen Worth, who you'll hear from shortly, the Gates Foundation, which is a key partner of FP 2020, has been investing in a number of adolescent initiatives to tackle some of these long-standing and thorny issues. And one of those is what we're going to hear about today, the Beyond Bias project, which is being implemented by Pathfinder International with YLabs and some other partners. So we're eager to hear about what they've learned and to think about how we can apply this learning and the types of programs and initiatives we support within FP 2020 and with our FP 2020 colleagues. I'm beyond confident that you will find this presentation of significant interest. Just to orient you to the format, we have Lydia Murithi from Pathfinder, who's going to discuss the overall thinking behind Beyond Bias. We have Theo Gibbs from YLabs, who will walk us through how Beyond Bias came into being. And we have Bram Brooks from Pathfinder, who will discuss some of the findings from monitoring and evaluation. And I do hope we have some time for some questions from our audience, which we invite you to input into the chat box. We may not be able to respond to every question today, but we will do our best to respond after the webinar. We really thank you all for being here today. So before we start, however, I'd like to turn it over to Gwen for her thoughts and observations. Gwen?
Thank you, Kate. Good morning, good afternoon, good evening, everyone. I'm Gwen Worth. I'm the Senior Program Officer for Adolescents and Youth on the Family Planning Team at the Gates Foundation. And I just wanted to kick us off by providing a very brief background on why the Gates Foundation undertook this investment on provider bias for youth. So as we were looking at where we most wanted to invest to really increase universal access goal, one of the things that we were clear on was that to improve universal access, including for adolescents and youth, we needed to address system and user barriers that were preventing young people from accessing and using contraception. And as Kate mentioned, one of the most reported barriers to young people's use of contraception has been provider bias and or fear of judgmental behavior by providers. And also, as Kate was saying, despite provider bias being such a pervasive barrier, the field's primarily relied on training and to some degree things like values clarification to address it. And, totally agree with Kate, and I think the broader community would agree that's had pretty limited success. So we really hope that by, providing some funding that could support a multidisciplinary approach that included human-centered design, we might be able to gain a deeper understanding of the different drivers of provider bias and also design innovative solutions that had the potential to be scaled. By working across different geographies in both the public and private sector, we hope this investment would generate solutions that could be adapted, scaled across different contexts and health systems. And I'm going to stop there because I think, you know, we all want to really hear the meat of this webinar. And so with that, I'm really excited to hand this over to Lydia Murithi from Pathfinder International, who is the director of the Beyond Bias project. Lydia?
Well, right. Thank you very much, Gwen. And hello, everyone. Thank you for tuning in. So before we get into the presentation, I would like to introduce my colleagues and co-presenters who Kate mentioned briefly. We have online Theo Gibbs and Bram Brooks. And Theo is a design lead at YLabs, and she led the human-centered design process for the Beyond Bias project. Bram is a monitoring, evaluation, and learning senior advisor at Pathfinder International, and he supports the Beyond Bias project from the MBL front. So the three of us, as Kate mentioned, will tag team the presentation. And let's get straight into it. So in today's discussion, we aim to accomplish three objectives. One, provide an overview of the provider bias approach. Provide an overview of the Beyond Bias project approach, sorry. And number two, describe the behavior change strategy we have developed and are currently implementing. And three, share some reflections and insights we have gleaned along the way on how to tackle bias. Now, we hope to get through the presentation in about 45 minutes and then open it up for about 15 minutes of Q&A. So please do note your questions as we go. And actually, you can type them into the chat box, and we'll do our best to respond to as many as time allows in the end. Now, getting into the challenge of provider bias, as both Kate and Gwen have very well articulated, provider bias remains a global challenge as it relates to unmet need for contraception among adolescents and youth. But you might be asking yourself, what exactly is provider bias and how does it present? And so for definition purposes, when we talk about provider bias in contraceptive services, we are referring to judgmental attitudes and behaviors of providers towards young people, either due to their age, marital status, or parity. So for instance, this could be a provider's beliefs that a young and married woman should not be sexually active, or that a young married woman should prove her fertility before using contraception. Next slide. We refer to provider bias as a last meter challenge. And this is because it occurs at that last step towards access. And that is during that moment of consultation between a provider and a young person. Now, as you know, there exist multiple other barriers that prevent young people from accessing contraception. But what makes provider bias an especially problematic barrier is that it could render other efforts and investments that we make towards reaching young people with contraception futile. For instance, any investments we make in policy development or demand generation activities or commodity procurement will not amount to anything much, really, if by the end of the day a provider turns away a young woman without a method. And this is why we say that provider bias is a challenge that we must surmount. Next slide. Gwen and Kate have very well noted that globally efforts to address provider bias have so far centered around training and supervision of providers. And though these approaches have been helpful to some extent, they have failed to fully address this deeply rooted barrier to care. Next slide. And so it is against this backdrop and background that the Beyond Bias project was conceived, with a mandate to design and test scalable, innovative solutions to address provider bias. So in other words, we are charged with the responsibility to disrupt the status quo on how the field responds to this enduring challenge. We focus on youth and adolescents ages 15 to 24 and are currently working in Tanzania, Burkina Faso, and Pakistan. In Tanzania and Burkina, we are working with the public sector, and in Pakistan in the private sector. The project, which is a collaboration between Pathfinder and our partners YLabs, Kimber Collective and Berry, employs a comprehensive multidisciplinary approach, combining existing AYSRH expertise and evidence with the human-centered design, behavioral economics, and segmentation analysis. Now, I'd like to quickly note here that human-centered design, or HCD, and segmentation analysis are both methodologies borrowed from market research, and we are seeing them increasingly used in global health to spark innovation. So with this presentation, we'll demonstrate how we've integrated these methods into our intervention design. Next slide. As you can see from this diagram, the program employs a phased approach, and we have 3 sequential phases. That is the research phase, the intervention design phase, and the implementation phase. We began with the research phase by conducting a global literature review to understand the drivers of bias. We then followed that with design research, which included primary data collection in the 3 geographies. So these are 3 countries we're working in, with the aim to get an in-depth contextual understanding of bias as they present in those countries or in those contexts. And we then completed a segmentation analysis to get a nuanced understanding of behavioral and attitudinal characteristics of providers. Using evidence and insights generated from the research phase, we then launched into the design phase, where we used HCD approach, or the human-centered design approach, to generate ideas, then iterate them by testing them with providers, youth, experts, and stakeholders. In today's discussion, we will share with you the resulting intervention, which we're also calling here a behavior change strategy that has come out of this process. And with regard to timelines, we are currently in the initial stages of the implementation process, where we'll implement the intervention for a period of 1 year and rigorously evaluate its effectiveness through an RCT. Next slide. So this slide pretty much summarizes how the various methods were integrated into the design process. A key point I want to note here is that to bring rigor to the design process, we constituted a technical advisory board made of Pathfinder AYSRH experts and other partners who vetted the solution at 3 points of the design process, as you can see noted on this slide. And this was to ensure that the evolving concepts and design were grounded in evidence and practice. So in summary, our design process was evidence-driven, iterative, and corroborative across partners and disciplines. With that, I'll turn it over to Theo to walk us through the research findings and how we integrated them more into the design process. Theo?
Great, thanks. Just want to check you can hear me?
Yes.
Yes, okay, perfect. Wonderful. Hello, everyone. I'm going to talk through some of the key findings from the initial phase, which Lydia mentioned, of the research. So basically, to start off, in order to design an intervention that had a chance of succeeding, we really needed to deeply understand what bias looks like, what drives it, and also, what the daily constraints of providers are when it comes to behavior change. So to do this, we conducted a quantitative survey with over 800 providers. This was led by Kimber Collective, as well as in-depth qualitative interviews with nearly 400 providers and young people across the 3 countries, with that work being led by YLabs. So through this mixed methods approach, we were able to identify 11 key drivers of provider bias towards youth. And this is the first project to rigorously identify and classify drivers of provider bias across multiple diverse country contexts in this way. And in doing so, really contribute to the literature, which is quite slim. So the summary of those drivers is there were 3 primary buckets of drivers that were found, which you can see on the slide here. So those were biographic, situational, and societal. So biographic is, for example, negative attitudes. So whether or not a provider views sex as a healthy part of life for young people, or product and experience, whether or not a provider has direct experience using a family planning method herself. And then situational was, for example, workload. So how many clients does a provider have in a day? Or clinic reputation. So is a provider concerned about community backlash? And then societal were comprised of social norms. So these are social norms, for example, the larger social norms that a provider is sitting within. So taboos against premarital sex in her community, his or her community, or the expectation of young women to prove fertility, immediately after marriage. And so there's 2 key points I want to highlight here. One is that most of the drivers that we identified of the 11 are not because of characteristics that are inherent to providers as individual people, right? It's not, a provider isn't biased because she or he is a bad person. It's because of the situational context and social context that the provider is existing within. So that was important for us to keep in mind as we were looking at how to design an effective intervention. And then another point to highlight is looking across all of these 11 drivers, the 3 that are in bold and italics on the screen are the ones that were the strongest identified across the 3. So those were fear of competing SRH risks. So for example, fear of HIV transmission from use of non-barrier methods, clinic reputation, so that fear of community backlash, and then social norms. So then one of the interesting aspects of this project, as both Gwen and Lydia mentioned, is the use of segmentation in combination with human-centered design. So for those of you who maybe aren't familiar with segmentation, segmentation, it's a technique that has been traditionally used in marketing, and it's a quantitative analysis process to identify associated clusters of data within a survey data set, and thereby identify different groupings of respondents, in this case, providers. So each group or segment of providers is defined by a set of particular tendencies and attributes. So in this case, Cambridge Collective, who is a partner who led segmentation, used the survey data to identify those 11 drivers of bias, which I just mentioned, but then also identify 6 segments of providers, which appear across the 3 countries that we're working in. So each of these segments has a distinctive way that bias shows up in interactions with clients, and a particular mix of those 11 drivers behind their biased behaviors and attitudes. So the reason why segmentation is valuable in a project like this is that, as we know, providers are diverse in their reasons to deny service. And segmentation allows us to account for that diversity and then tailor interventions more precisely, thereby hopefully increasing the likelihood that a behavioral intervention will stick. So in this presentation, I'm just going to give a brief example of 3 of the segments of the 6 that you see, and how bias shows up differently among them, so you can get a sense of that. And I welcome all of you to download the full segmentation report, which is available on Pathfinder's website, and the link is there below. Great. So as I said, as you could see probably from the last slide, each country has a segment that is predominant. And so that means that how bias manifests is slightly different in each country. So in Tanzania, in this case, the average passive segment is the dominant one. And so this is a segment that's characterized as moderately trained, but mistrustful of long-acting methods and hormonal methods, and worried about HIV risks. So a way that bias shows up is that a provider might require clients to take HIV tests before giving services. And I think the quote at the bottom, which is from qualitative research, helps illustrate some of the human conflicts that providers are struggling with. So a quote from a provider there: "I feel guilty giving injections to young women because they will not be able to later conceive at the right time." And then in contrast, in Burkina Faso, the dominant segment, the detached professional. And so this is a segment of providers that's characterized as well-trained technically, but they face high workload stress and client load. So they often don't do full counseling on all methods, and they prioritize older clients, and are also likely to promote abstinence to young unmarried clients. So a quote from a provider in Burkina: "I have too many patients and too little space. Sometimes women deliver on the floor because we don't have enough tables." And then finally in Pakistan, the dominant segment there was the content conservative. So this is a segment characterized as having very low training on AYS or H, and very reluctant to give any type of family planning service to unmarried clients due to social norms. So the way that bias shows up for this segment is that there's high rates of discouraging long-acting methods for zero parity clients due to the provider's misinformation and the provider's fear of the fertility impacts. And a quote from a provider in Pakistan: "For newlywed clients younger than 20 years, I advise them to conceive once, then go for birth spacing." So in summary, segmentation, I think, helps us identify those important differences between in provider behavior and motivation across the 3 countries. And we'll give some examples later on in the presentation of how we use segmentation in the design process to tailor the intervention. And then, so as I mentioned, we also did interviews and focus groups with over 150 providers for this project. And so in addition to the segmentation, this qualitative work, I think, helps us understand more of the why behind provider behavior and identify some common themes underlying provider behavior across the 3 countries. So I'm going to share 3 of those underlying qualitative insights now. So the first cross-cutting insights that we heard across the 3 contexts were that wanting what's best for a young person can actually be a driver of bias. So what we mean by this is that many providers see themselves as protectors of youth. And so when they send patients away or recommend abstinence, those actions are often coming from a place of concern rather than emotional disconnection or the provider disliking the young person. So the implications of designing for behavior change is that we knew that we would need to connect providers with the down the road consequences of their good intentions and help them see how they have this good intention, but the consequences actually for the young person's life are not positive. And then second, we knew that we need to correct method misinformation that providers hold because they're acting from the best information they have. So we need to correct it when they do have method misinformation. And then second, cross-cutting insight was that providers have one foot in the community, one foot in the clinic. So this is building on some of the drivers identified by segmentation around social norms. So many providers fear community backlash for giving services, and providers are often struggling to reconcile professional norms with social norms that are, for example, prohibiting sex before marriage. So when we were thinking about designing for behavior change, we knew that we would need to look to have strong institutional support and give providers a sense of institutional permission in order to shift those professional norms about serving youth. And second, as Lydia had mentioned, and Gwen and Kate as well, we knew that we'd need to move beyond a one-time approach of training because biases are deep and entrenched beliefs and behaviors. So we would need to have repeated nudges with providers in order to probably be successful. And then the third cross-cutting insight was that we heard that providers want to feel like and be seen as the expert and decider. So for example, during the research, when we asked providers to map what their best day and worst day looked like, it was clear that they got satisfaction when the patients accepted their method recommendation without questioning. And so for providers, being the expert often means making that method decision. And they feel competent and respected when a client accepts that decision, which is important in an environment where often they feel overworked and devalued. So when we were thinking about designing for behavior change, it was important we knew that we would need to ensure that providers would feel institutionally recognized for being in an expert guide role and supporting informed choice for youth rather than being in this expert decider role. So these are just 3 of the cross-cutting insights that we found through the research. And again, you can download the full design research report on Pathfinder's website. So that's a quick, high-level summary of the findings from segmentation and from the qualitative work. And so now I'm going to give you an overview of how we took that foundational research into the human-centered design process for intervention development. So we started with idea generation. And so as a project consortium and with key stakeholders in each country, we generated well over 100 ideas. And you can see a small portion of that colorful mosaic here. So we then selected 7 ideas to go into rapid prototyping. And those concepts of those 7 ranged from generating empathy to technical training to performance-based rewards. It was a very wide spread. And they were tailored to the segments, which I described earlier. So for those of you who aren't familiar with human-centered design, rapid prototyping is basically a way of testing and evolving ideas directly with your users, in this case, providers and young people, using inexpensive materials in simulated settings, so not in real clinic environments. And you can see an example here on the slide, the photo from Pakistan of some of the paper prototypes that we tested with providers and youth. So we tested those 7 concepts quickly over a 3-week period in each country. And then based on the ref prototyping data, we then selected the 3 most promising concepts to combine together into a more refined form and move into a 3-month live prototyping period. And so live prototyping, in contrast to ref prototyping, is sort of like a mini pilot. So it feels like a real program to the user, and you do it in real clinic environments, but you're still changing the solution through the testing period based on user feedback and data. So you can see a photo here from the live prototyping period in Tanzania. So we live prototyped in each country for 3 months with 29 facilities. And through that, we identified how we could further strengthen the intervention into one integrated package before taking it into implementation, which is what we are currently in the middle of. So the value of this cyclical human-centered approach is that we are able to directly test and evolve and actually co-design ideas, intervention ideas with young people and providers, and evolve them based on that feedback, rather than just coming up with an idea ourselves and then jumping right into implementation. So just to give you a sense, at each stage of selection and assessment between those cycles, we used a few core criteria. So those were desirability to providers who are our users, potential impact on behavior change, feasibility to implement by Pathfinder in our partner facilities, and acceptability to key stakeholders. And then, of course, potential for scale was a critical criteria that we considered at each stage in collaboration with an advisory board of key stakeholders in each country. So with that, I'm going to pass it off back to Lydia to talk about the actual details of intervention design, which is the result of this human-centered design prototyping process.
Right, thanks, Theo. So for the remaining part of the presentation, we'll give you an overview of the intervention that we designed through this process that Theo just took us through. And like I mentioned earlier, we are currently implementing the intervention in 3 countries, and we'll be evaluating it after a period of 12 months. So from a user perspective, the user here being the provider, the program has 4 key steps: activate, apply, achieve, and advocate. And these steps are intended to create a loop which repeatedly reinforces desired shifts in behavior over the course of the intervention. So in the coming slides, we will discuss the 3 core elements or pillars of the program, how we have tailored it to the dominant segments in each country, as Theo mentioned, and then how we expect these pillars to work together as a system to shift provider behavior. So in the activate stage, we have our first component or pillar of the intervention, which we call the summit. Now, the summit is a story-driven event designed to build empathy for providers on the plight of young people and ignite their motivation to serve the youth. And this is the first touch point or entry point into the program for the provider. So at the summit, we bring providers together and they get to hear stories from young people about their lived experiences with denied care and the consequences they've suffered as a result. And these are usually quite emotional stories that demonstrate how a young person's life trajectory changes as a consequence or as an impact of being denied contraception. So a story could be, this could be a story of a young person visiting a facility or clinic on various occasions and getting turned away each time, then ending up pregnant, dropping out of school, maybe being shunned or rejected by her parents and our partner, and maybe now struggling to raise a child of our own. As you can tell, these are quite weighty stories, and they're meant to awaken providers to the gravity of their decision in the lives of young people. So in addition to these impactful stories, we also invite respected authority figures as key speakers or guest speakers into the summit. And this is to affirm and inspire providers. So for instance, in Burkina, in Tanzania, where we are working in the public facilities or public sector, the guest speaker would normally be a representative from the Ministry of Health. And in Pakistan, where we work with private providers, we would invite a respected senior medical professional. What we find is that the presence and support of these guest speakers or key figures provide providers with some sense of social permission to serve youth, which helps in decreasing their fear of community backlash. So then, using stories and inspirational dialogue as an entry point, we walk providers through a journey of guided reflection, helping them to develop self-awareness of their biases or their own biases, and then provide them with a safe space where they can engage one another openly and without judgment about their inner struggles with bias. And finally, before the end of the summit, we encourage providers to engage in an exercise of action planning where they make public commitments to serve youth. Next slide. So as Theo mentioned earlier, the content of the intervention is tailored to dominant segments in each country. And so what you're seeing here is an example of what that looks like in a summit. So see, one of the attributes of detached professionals, which is a segment in Burkina Faso that makes about 80% of providers in Burkina, is that they're likely to promote abstinence to unmarried youth. So the story told by a young person at a summit in Burkina will be one that recounts a lived consequence of this kind of advice. And we all know how that kind of advice ends. And in Pakistan, where content conservative segment is 70% of providers here, these are likely to deny modern methods to nulliparous young clients. And this is given the expectation for them to prove fertility, which is a strong social norm there. So the story here would center around a lived experience of such a client, or a client who's been denied and asked to have a child first before getting contraception. Next slide. So a key lesson we've learned while testing the summit with providers is the need to humanize bias and support providers through a journey of guided reflection. So we discovered that most of the times providers, even when trained, and actually especially when trained, we found that they struggle. They have a conflict between their personal values and the standards of care expected of them. So unless providers are willing to confront these internal conflicts, no amount of training will really change them or shift their biases. That's what we've discovered. So to humanize bias, we acknowledge providers' internal struggles or providers' struggles and constraints, as well as best intentions, but still hold them accountable. So a valuable lesson here is that of naming bias without shaming or condemning providers. And we found that this has worked well. This is what works well to support self-introspection of providers. Next slide. So here's a quote from one of the providers in Tanzania during a guided reflection session at a summit. And he says, It's true that there may be gaps in training, but the problem lies within. Today, I came to understand that sometimes my services to youth can be changed by my own bias. Then with that, I'll hand over to Theo to walk us through the connect pillar.
Great. Thanks, Lydia. Great. So next comes in the intervention design comes the apply phase. And so we know that new habit formation takes time, and especially for socially entrenched behaviors like bias. So as you heard, and as you know from literature and also from our direct research, we knew that the one-time summit, it could be a powerful event, but just that event alone was not going to be enough. So after this one-day activation event, the summit, the provider is added to the Connect forum with her peers. And so Connect is an ongoing support and learning forum that's designed to reinforce unbiased practices and enable providers to support each other when they encounter challenges on their day-to-day level. So taking their motivation and actually helping them apply it on the daily consultation level. And so what we designed is that Connect can be facilitated digitally, so via a WhatsApp group, which is what we're doing in Pakistan, or in person at the facility level through sessions led by facility managers. And this is what we're doing in Burkina Faso. And then we're actually doing a blend of digital and in person in Tanzania. So through the prototyping process, we tested Connect with 29 facilities and over 100 providers and facility managers in the 3 countries. And so we learned a lot about what providers found valuable and attractive for this sustained engagement forum. And so here are 4 ingredients to highlight. So first, it was really important that the forum had realistic case studies, believable case studies that could drive discussion among providers and help them practically apply knowledge. So realistic case studies supported providers to help reflect on their specific facility environment and then identify, how can I apply unbiased practices in my own daily schedule. And so we saw that this type of place-specific reflection was important to cement habit change and providers' commitment. And then second, it was important for providers to have access to trusted and relatable technical experts. So this was an attractive feature of the forum. And for providers, what we heard is that a trusted expert was someone who was an accomplished provider themselves, kind of like or who had direct experience in their country context. And then third, we heard that Connect needed to feel like a safe space where providers could share struggles and celebrate each other. And what we heard was that, providers having the space to openly discuss about challenges and successes in working with youth clients was a key value for them of this forum that they didn't have access to elsewhere in their job. And then finally, Connect was used as a way to regularly remind providers about the commitment that they made at the summit, and in doing so, shift group professional institutional norms. So similar to Connect, the Connect content in the curriculum was adapted to the segments in each country. So continuing the example that Lydia started, so with the detached professional segment in Burkina Faso, we have, for example, with the real case or with the relatable case studies, that the case studies in Burkina Faso would focus on younger adolescents around 15 to 17 years of age that highlight their emotional experience, because that's the type of client that segment is more likely to deny modern method counseling to. And in Pakistan, with the content conservative segments, the case studies focus more on a married woman without children yet who's seeking a long-acting method, and that's to address that particular segment's fear of the fertility effects of long-acting methods. So just like the summit, we prototyped Connect in we prototyped Connect for 3 months in each country in digital and in-person formats with providers. And so through that, we adapted the format and the curriculum based on our learnings. And so this process is very valuable to actually get direct feedback from providers about why they would keep coming back to this forum. So for example, in Pakistan, we're working with private sector solo operator providers. And through prototyping, we saw that provider engagement on the forum increased dramatically when we added in business and marketing advice, because these are solo private sector providers, in addition to the AYSRH content. And so thus in the program that we're currently implementing, the curriculum has a blend of medical AYSRH experts, but also business and marketing experts and tips, since that is a key reason why providers see the forum as relevant and worth their time and continue to come back to on a daily basis. So here's a quote from a provider in Pakistan about her experience of the Connect prototype. So she said, "We felt like family. It is a safe space where we can freely express whatever we think. Even our life stories were shared on the forum. I didn't fear that someone will criticize or reprimand me. Through Connect, I learned many new things. I felt valued on Connect." So, overall in the solution model, Connect allows us to move beyond that traditional kind of one time, one and done technical training and move to have more sustained, continued engagement with providers. And additionally, the option of digital or in-person increases the ease of replication and adaptation across the three contexts that we're working in, and hopefully more broadly than that. And so with that, I'm going to pass it to Bram to talk us through the third part, take us home with the Achieve phase.
Great, thanks, Theo. All right, we now move to the Achieve phase and talk about the rewards component of the intervention design. Rewards, in essence, is an incentive program based on provider performance. Every quarter, facilities receive report cards with performance data based on real client feedback. And based on the results from these client feedback, we're able to use this information to come up with recommendations for improvement. As part of the reward system, we're also able to identify high-performing facilities who get public institutional recognition if they are making progress in reducing bias in youth service provision. So after prototyping the rewards program with 29 facilities over 3 months across our 3 countries, we identified several core ingredients of success. We realized that we needed a standardized rubric of excellence for unbiased care that facilities can work towards and develop new institutional norms around. I'll talk about this rubric for measuring unbiased care in more depth on the next slide. We also learned that gathering feedback directly from clients after FP service provision created a sense of direct accountability. This was accomplished through client exit interviews in health facilities. And finally, we also realized that institutional recognition on a quarterly basis through a small reward ceremony, along with recommendations of areas for improvements, not only provided feedback for how providers can improve, but also provided an incentive mechanism where providers were competing with one another. So in order to be able to measure progress in the reduction of bias, we first needed to articulate and align clearly on what is meant by unbiased care, as there is no real measurable definition in the literature. From the technical review of the evidence and with the partnership of our technical advisory board, which include Dr. Chandra Mooley from WHO, in addition to Kate Lane, we developed the 6 principles framework that you see on this slide. This framework is helpful as it guides providers to better understand what unbiased care means for youth. It also serves as a foundation to measure the impact of the overall intervention design. This was a cross-cutting framework developed and tested with providers. Each principle has measurable indicators attached to it. These indicators have been developed through a consultative process and rely heavily from existing measures of FP quality of care, mostly developed by Measure Evaluation and WHO. So in summary, we have key questions across our client exit survey that map to these 6 principles so that we are able to calculate not only the overall score for unbiased care, but also performance for each of these 6 principles. I'd be happy to discuss elements of this framework during our Q&A session. We prototyped the rewards program alongside the other 2 components over a 3-month period in each country before starting implementation. One of the key things that we learned in prototyping is that ranking providers by their performance can be a demoralizing effort. And since this is a difficult set of behaviors to change, so instead we decided to focus on rewarding a facility's relative progress over time rather than its absolute performance in order to keep providers motivated. We also tested an array of client feedback tools, since getting accurate service experience data from youth, many of whom are illiterate, is not easy to do accurately. An example of one tool we tested with over 3,000 clients is shown on this slide. We had a headset and tablet set up in an ATM-like kiosk in the clinic so that non-literate clients could complete an exit survey with audio and visual guidance. The pictures on the slide are examples of the survey of the questions seen on the tablet from the client exit survey. And as you can see, these questions relied heavily on easy to understand visuals and audio prompts. It's how to put on your headset to listen to questions, swipe the screen to move from question to question, or select the various EP methods that one is interested in using. What we learned a lot about what works and what doesn't in collecting service quality data from youth is a topic for another full webinar. There are so many interesting pros and cons from a self-administered versus enumerator collected client exit survey. I presented examples of kind of the visuals from a self-administered survey. And in the end, we actually decided that it would be more strategic to do a client exit interview led by enumerators. But in any case, if folks have questions, we'd be happy to answer some of these queries and comments during our Q&A period. There was a lot of information shared about the rewards component of the intervention design in a short period of time. I'll end this section by sharing a quote from a provider in Tanzania that nicely captures one of the key themes that came out of the qualitative data regarding the potential role of rewards in improving providers' motivation to change their behavior. I changed my perspective and attitude towards young clients. My priority is serving youth just after the moment I knew my efforts would be recognized. All right, I'm going to turn it back to Lydia to talk about how all three components now work together.
All right, thank you, Bram. So bringing all the three pillars together creates a robust behavior change strategy, which we believe has potential in shifting provider bias. And as we've demonstrated throughout the presentation, each of these pillars draw from existing evidence as well as insights we have gleaned through testing with providers. So I'm going to sum it up, sum the behavior change strategy here. And in summary, key behavior change mechanisms we found to be crucial for the summit is one, the need to humanize buyers and guide providers through a process of self-reflection. And two, build their emotional connectivity and empathy for the youth. And three, address their fears of community backlash. And the community backlash part again was by inviting key speakers such as people from the Ministry of Health to be able to connect the program with AYSRH policies in country. So in other words, affirming providers' work. So for Connect, we found it is critical to address providers' concerns about fertility delays and educate them around the safety of methods for youth. And we also found it is important to activate their agency to, problem solve and come up or find homegrown solutions to the challenges they face. And for rewards, it is important to create a system of accountability and offer visible rewards to recognize providers' performance, but also most importantly, recognize their growth. So together, these pillars work to reinforce desired behavioral shifts in providers. So getting you again through the journey, through the summit, providers activate their motivation and self-awareness of buyers, and through Connect, they then apply the knowledge and motivation supported by a community of peers and trusted experts, and through rewards, they achieve recognition and performance. And you might be asking then, where did Advocate go? An interesting observation we've made during the user testing with providers is that providers actually, some of the providers who go through these three pillars, that is the summit, the Connect and rewards, become champions and strong advocates for youth. And so in return, they motivate and activate their peers to better serve youth, and the cycle repeats itself again. So forming somewhat of a virtuous cycle of shifts in provider attitudes and behaviors. And ultimately, we hope that these shifts will result to unbiased, high-quality services for youth, as articulated by the 6 principles of unbiased care, which we presented here as the outcomes, the key outcomes on the right side of the slide. Next slide. So to give you a flavor of how providers are responding to the program, here's a quote from Manas in Burkina. on how the three pillars work together. And she says that the parts are interwoven. Because of the summit, we realized that there was a problem. Connect challenged us about how we do our work because we saw that it is not the client who is a problem, but rather the provider who must ask herself, what can I do to make my service accessible? And third, which is reward, is crowning it all with its importance for job satisfaction and a sense of recognition. So all the three parts are important. So that was such a great affirmation of the model, if I may say so. And actually, this sentiment about the importance of the three pillars and how they work together as a system to change provider behavior was a common theme echoed across many providers that we tested with. Now we can only hope that these actually translate into the implementation as well, and we continue to see these working the same during the implementation period. So though we are currently partway through the implementation, we have generated critical evidence and insights that is from the research and design phase that we hope are valuable to inform ongoing AORSRH programming. And hence the reason we are sharing this with you during this webinar. And key outputs include, one, foundational research on global drivers of bias, and we've done this. We have an available global lit review on this, and we also have contextualized insights on these drivers in Tanzania, Burkina Faso, and Pakistan from a design research that we completed in those countries. Number two, we also have provider segmentation tools that could be used to classify providers based on their demographic, behavioral, and attitudinal characteristics. Now, remember when I started, I did mention that segmentation analysis is coming from market research. So in the field of global health, what we've normally done is normally segment or classify our target groups with demographic, by looking at the demographic variables. But for the segmentation, it adds behavioral and attitudinal characteristics as well. So we have that tool available. And number three, we have the 6 principles of unbiased care, which provide a framework to define and measure bias. Now, from WHO, we do have standards of care and youth-friendly services, what youth-friendly services look like. But when we started doing this work, we realized that there wasn't any clear definition that was tangible to really measure provider bias and to be able to assess it. So we did develop the 6 principles that serve as a rubric to measure and a framework to measure and define bias. And finally, we have this promising adaptable behavior change strategy to tackle bias in contraceptive service delivery, which we've shared with you today. And we actually believe that this behavior change model is not only adaptable by country and beyond, but could also be applied to tackle biases in other areas of sexual reproductive health, such as maternal health care and HIV. So to access these materials, please do visit our website or contact me via email, and the details of that are now available on your screen. Finally, and I know I've mentioned this a couple of times, and I'll just like to reiterate, we are currently in the early stages of implementation, and we are implementing this strategy, the behavior change strategy we've talked about in our 3 focal countries. Implementation began in September of 2019, though our countries are staggered in starting the implementation, and they will conclude this year. So towards the end of the implementation phase, our evaluation partner, Berry, will conduct a randomized controlled trial to evaluate the impact of the program on provider behavior, and also, the leading, or hopefully the effects of these changes that we would see, or whether there's any change we'll see in the quality of services that our young people receive. And what you're seeing here on your screens are some of the branded materials we have installed in facilities during implementation, courtesy of our design partner, YLabs. So with that, I'll hand it to Kate to moderate Q&A. And thank you very much for your attention.
Wow, so that is what I call a small but mighty project. There are so much interesting findings coming out of what Beyond Bias is doing. I really think this kind of epitomizes some of the work that Gates is trying to do around disruptive innovation. So we had over 300 participants on this call and a ton of questions, which we can't possibly get to in the next 6 minutes. The first question that I think I'll share with the group here is, will you share these slides?
Yes, we're happy to share the slides, Kate.
Okay.
Absolutely.
One of the questions that's coming up regularly is, will these slides be shared? So yes, we will share these slides out. We are also keeping track of all the questions that are being asked. To the extent possible, we will share these with Pathfinder and Beyond Bias, and we will try to respond to these particular questions. But I just, in the 6 minutes remaining to us, I just wanted to ask a couple of questions that kind of rose to the top for me. One question was around the role of young people. How meaningfully were young people engaged in this overall process? Maybe that's a question for Theo.
Sure, yeah, that's a great question and something we're always thinking about at YLabs with, how do we ensure that our intervention design process is youth-led and really centers young people in that design. So during the design research, well, during all phases of the project actually, but during the design research phase, we interviewed young women and young men in all 3 countries as part of that formative qualitative work in interviews and focus groups. We also did co-design sessions with young people during the design research phase. And then during the prototyping phases, so rough prototyping and live prototyping, we involved young people with giving feedback on the ideas, and also helping us throw out ideas and come up with new ideas that better served young people. So this was an interesting project, of course, because the end beneficiary is the young person, but the user is the provider. So we were in all of the phases, we were engaging both providers directly to give feedback and help us evolve ideas, but also engage young people to make sure that it was centered around their needs.
Thanks, Theo. Here's another question that popped up a couple of times too, is we know that not all of the biases that providers have are negative, or the behaviors. So were there attempts to build on some of the positive aspects of provider interactions with young people? Lydia, you want to field that?
Yeah, so one of the things we learned actually is that one of the key drivers of bias is that providers want to do what they think is best for young people. And so sometimes that could lead to negative, outcome when it comes to how they serve the young people. So I'll give a practical example. So like in Tanzania, for instance, we had a provider saying, I really do want to serve a young person, but when a young person comes through the door and asks me for an implant, then I'm just worried about the fact that if I give her that, she will contract HIV because you go and have sex without caring and get HIV. That's a practical concern that these providers have. But how we've worked with providers is to help them understand that you can actually provide a dual, give an implant, but still recommend condoms to young people. So, and the fact that, helping them really walk through the process of reasoning, which is that the fact that young people are getting pregnant, because that's the whole process, the reason why unmet need for contraception is key, it means that they're already having sex and they're already having unprotected sex. So you encourage them to have protected sex, but you don't deny them a method that could help them prevent pregnancy. They do have unprotected sex. So those are some of them. And we also had providers who we call positive deviants. And these were very instrumental in our discussions during the summit, and actually are being part of the moderators of the Connect, the WhatsApp Connect or in-person Connects. And these are providers who just generally out of either their own personal experiences, maybe because of denying a method and then seeing what it does to a young person, or having an adolescent themselves, they've shifted their thinking around how to respond to young people. And with these providers, we actually build them and hope, we actually believe that they're the future of this project and the scalability of this project, because those are the advocates who we engage. So yes, we do build on what providers have, the knowledge they have, fill in the gaps, as well as support them through this journey.
Thanks, Lydia. One last question, because I know we're coming up on time, is, one of the things we know is providers face incredibly heavy workloads. How were you able to motivate providers with these heavy workloads to support the provision of services to young people, which can take a lot of time in clinic settings?
Right, and that is a practical issue that they deal with. And one of the things I mentioned during my discussion with Summit is that we do acknowledge that providers have constraints and they're not working in an ideal situation. So what we do, we encourage providers to do is, within the constraints that you have, we understand that there's so many constraints. What can you do on your own or with your peers to do a better job? So for instance, that's what we're talking about, ingrown solutions, because obviously, infrastructure is an issue. A lot of workload, especially, that came up a lot in Burkina Faso, where providers would normally just deprioritize a young person because of the workload. One other thing that we help providers understand is that this young person you're deprioritizing today, because you think, you want to attend to an emergency of a woman who's giving birth, is actually the same woman or that person you will prioritize 12 months down the line because she'll come in pregnant. So creating these connections to providers, and they would sit back and actually say, I've never thought about it that way, that the young person I send away without a method today is my emergency 12 months down the line. So helping them see the gaps and how serving young people is a long-term solution to the emergencies that they face, as well as helping them, build their own ingrown solutions. We had providers actually providing curtains, coming in the clinics with curtains, and to create some level of privacy when they're serving youth. So all these are ways that we're working with providers to overcome the constraints that they face. So
I've just had a note passed to me that we actually have until 10:15. So if people want to stay around for another 14 minutes, we will field a few more questions. If you, Lydia, Theo, and Bram, if you're okay with that.
We hear.
Great. It was a very interesting question at the very beginning of the presentation that talked about bias in policies, where I think this is one of the challenges we face, is sometimes there's a disconnect between what policies say and what providers are willing to do. Have you thought about other ways in which this kind of methodology could be applied to other aspects of biases, like institutional biases within like ministries of health?
So like I mentioned before, we hope that this approach would obviously is adaptable and could be applied in various forms in addressing biases in other contexts other than provider bias. And so I would imagine you would take some elements of this, where you take, whether it's government representatives or Ministry of Health, folks that you're working with, and maybe provide a face, give a story, use a face or impactful story to sort of connect them to the issue. Because what we see is that statistics are important, but sometimes people become very inured to statistics. And so putting a practical face to the issue, we find it to be very impactful. And so to the extent that we're able to incorporate that to sort of in policy development, maybe gatherings or discussions. And then the other thing is make sure that we have a way to support the process, which is what Connect is doing. And maybe some level of acknowledgement. I think that will be helpful. But just to again talk about the connection between the policy and the program itself, one of the things that we find is that in countries, or at least the 3 countries that we have, they do have adolescent AOSRH policies that actually do state that you can serve young people. But it is, what seems to lack is the implementation of these policies. So if a policy states, oh, you're free to serve young people, but the social norms are very strong in such a way that providers, because they belong to the communities that of the people they serve, then they have those conflicts within themselves, and they will not take the policy or the sentiments of the policy into action. And so this is where the provider bias concept or solution intervention comes to then help in implementing and actually giving a practical way of how you can implement that the policies that already exist. Because as we all know, in developing countries, we don't have a shortage of policies, but we do have a gap in implementing them.
Right. Another question that came up several times was around religion. And we know in these 3 countries that the faith community plays a role, whether it's the Catholics or the Muslims or other denominations. So did you see any kind of differences between in the providers as a result of these religious influences? Maybe Brahm or Theo?
Sure, I can speak to it. Yeah, I mean, certainly there's differences in religious composition among the 3 countries. And during the design research phase, we, in addition to providers and young people, also did some interviews with community leaders and religious leaders in those 3 contexts to get their perspective as well. I think the way that consideration of religion shows up in the design and sort of intervention design is that in every case or in the 3 contexts, religion showed up in the form of those social norms with regard to sexuality and sexual behavior. So the expectations of proving fertility, the expectations of not having premarital sex, those were the primary ways that we heard those, or we heard religiously informed views being expressed. And so we changed kind of our messaging strategies to, of course, adapt to those religious contexts in each of the 3 countries regarding, that religion's tendencies around young people and sexual behavior.
Thanks. Here's another question too, and I remember because when I was with Pathfinder prior to joining EPI 2020, one of the conversations that we were having was around the differences in connectivity in different countries, and so where some countries might have great connectivity to use WhatsApp groups, other countries, I think Burkina Faso in particular, had less connectivity. So that's another question about what do you do in these communities or these countries where connectivity is a challenge?
Well, Theo, I think Theo can speak about this because there's a lot we learned. Theo, do you want to take this on?
Yeah, sure. No, it's a great question. We struggled a lot with this, and it's a very real constraint. And so in Burkina Faso, as was mentioned, connectivity is an issue, especially for young people. We could talk about how that affected our solutions as we tested them with young people, but also for providers. Many providers didn't have smartphones or had data cell phone data in Burkina Faso is quite expensive, so they weren't willing to really do a lot of digital engagement. And so in the way that showed up in the intervention design in our case was we tested this digital format of Connect, the learning forum and support forum, and then based on the learnings in Burkina Faso of like, hey, providers really either can't or don't want to access digital engagement in this way, we shifted to change that format, and through the prototyping we learned that, and so we were able to shift to an in-person format, which is these short facilitated discussions around case studies and problem solving at the facility level that's led by the facility managers. And so we tested out that format in Burkina Faso instead as the alternate to digital, and it turned out to be have very positive feedback from providers themselves and also from facility managers, which was a little bit surprising to us. But facility managers said that it helped them have more alignment and motivation and cohesion among their team. So they found direct value in it. And so we definitely had to adapt to the different levels of digital access. Pakistan, every provider has a smartphone, and in Burkina, very few did. So that's why there's those adaptations in the model.
Here's a question. So I'm struggling to keep up with the flood of questions, like the proverbial fire hose. Which how do I select out? So in the next couple of minutes, here's one that just popped up that I thought was interesting: is what surprised you the most when you were out there collecting this data with young people and prototyping and testing with providers? And I think I'd pose that to all three of you.
I'll start.
Yeah.
I think for me, it was the fact that, when we started, as I said, the research phase, we did, a global literature review, but also Kemba did complete a survey to segment providers. And in Burkina Faso, bias was really subtle, to an extent that, from the learnings, or from the findings of this survey, which was a representative survey, a bias came across really subtle. And we started questioning, do we really even need to work in Burkina Faso? Because of, should we just go to another country where bias is stronger? But actually, when we followed with designed research, what we found using mystery clients is that bias was alive and well in Burkina Faso, but there was this gap or this difference in the survey findings, quantitative survey findings, and the qualitative way of looking at this. And we, for a while, do you pay attention to the generalizable data, or do you pay attention to what you're really seeing from the qualitative end? And through the process of testing, the key insight I was talking about this issue of providers struggling or with the fact that they would know, from training, they would know what they're supposed to do. So the desirability bias is huge, especially where you have training. And this is the case in a lot of provider training on youth-friendly services. And this was the case in Burkina Faso. So we learned that what we were seeing in the differences in data was the fact that providers in Burkina, because they were trained, they knew exactly what to tell you. But then when it came to them serving youth, when they closed that door and it was a moment of consultation between a provider and a young person, then they went back to their own personal values. So which means that the training doesn't really translate to provider change in their biases. And I thought that was quite monumental learning that has guided our solution development. Theo?
Sure. I think that's a great example, and I would share that sentiment. Another just small example that I'll add is that I think one thing that comes to mind to me that was surprising is the degree to which providers really jumped in and engaged with the WhatsApp group, the Connect in Pakistan. And through the rough prototyping, we had a sense of like, okay, providers will probably like this. But then when we went to the 3-month rough live prototyping period, we had well over 200 messages a day coming in on this WhatsApp group of providers talking to each other and sharing stories. And I think that it unleashed this clear need that providers, that solo, private sector providers were having to connect with each other and to share stories and to get information. And so that the degree to which providers really saw value in that connecting forum and sustained way was definitely surprising and encouraging to me.
Thanks. Bram?
Sure. I think what's surprising is just the challenges of trying to measure quality care. It's interesting. I think when we started developing the reward systems, you're trying to figure out some sort of feedback mechanism where you're trying to measure things objectively. Earlier iterations of our questions were asking, how did you like the service? It's a basic, 5-point Likert scale to get a sense, they liked it very well or didn't. And, things like, oh, they gave me water. So I viewed that as I'm getting great service. And it was kind of surprising to get a sense of how youth kind of interpreted what quality care meant. And it made us think to figure out, how do we find a balance of asking specific questions while getting to a more accurate sense of what actually constitutes biased care. So I think another surprise for me was the level of adaptation. You know, oftentimes we have an annual work plan that we just execute, but being able to iterate through various processes, stages of the project was also quite surprising and rewarding. You know, it keeps us on our toes, but you do ensure that you are working on activities that are relevant to the goals of the project, but that actually serve beneficiaries in the end. So that's all.
Yeah, I quite remember one of the interesting things was, I think it was in Pakistan, where young people, a mystery client young couple went in to request contraception, and the provider basically talked them out of using contraception, but she offered them a cup of tea, and they were like, oh, she was so nice. We didn't agree with what she had to say, but she gave us tea. And so, you know, she was rated as a good provider. All right, one last question. I will ask a final question before we go to closing is, did you see differences between the male and female providers? Are there any kind of differences in the types of biases that were demonstrated by men versus women? I'm guessing most of the providers were female, but were there any gender differences? And were there any differences in age, like younger providers versus older providers?
Yeah. Or Lydia, did you? I can respond.
No, you can go ahead.
Yeah, the gender question is an interesting one. I don't recall seeing. I don't recall seeing those differences in the qualitative work, and I don't think they were specified, or they weren't picked up as a critical difference in the segmentation, the survey data, if I'm remembering correctly. Age, though, was a provider attribute that did have a difference. So we saw that younger providers tended to be tended to have more willingness to work with young people and more openness to work with young people. It didn't necessarily mean they were less biased, right? Because they might be like, oh, like have this sense of like, I'm kind of like your older sister, or, you know, like I'm going to guide you the way that's right. But they did tend to like working with young people more. So that was something that we tried to, you know, with an earlier question asked about like, how do you reinforce some of the good things? We definitely want to encourage providers and those good behaviors of openness to working with young people, but guide them to understand that even your good intentions towards a young person might have negative consequences for her. So yeah, age did seem to have an impact on providers, how bias was expressed.
And I would totally agree. I would totally
Go ahead.
agree with that.
Anybody else?
Yeah, and I think there's a group where we have a paternalistic clinician where it was older doctors tended to show stronger marital and parity bias. So it seems like physicians that are older had a unique type of bias that they were displaying.
Right, that was particularly in Pakistan, with the huge distinction between paternalistic clinician and content conservative is that paternalistic clinician is a group of older, very conservative providers who actually in our design we decided not to focus on because we didn't feel like we had an opportunity to shift their behavior. But they made about 13% of the providers in Pakistan.
Right, and they were primarily in the private sector too, right?
Correct, that is correct.
So again, unfortunately we are at time. I there's still questions that are coming in, but we will share these with the Beyond Bias team, and to the extent that they're able to answer your questions. Some of them, I think they're more philosophical than anything, but we will share them, and hopefully they can get back to you with at least some responses to some of your questions. I see there's a real appetite for this information. So I hope perhaps, we can revisit what you all are doing in a few months' time and, update you with some new information. Really thank you all for coming in, signing up with us today to participate in the webinar. Thank our team. I thank the FP 2020 team for helping us put it all together. Stay tuned. I know Melinda Gates is really, really excited about this project. When we were at the ICPD Summit, she mentioned both FP 2020 and Beyond Bias in the same breath. So, there's a little relationship building that's going on there. So, again, thanks so much for joining, and we will post the slides, or somehow we'll get them out to you. We'll figure that out with Pathfinder, and look forward to revisiting this topic maybe in a few months' time. Thanks again.
Thank you. Thank you so much.
Thanks, Kate.
All right.
Great job, everybody.